Thank you for taking time out to attend this webinar. And well, I think this evening is going to be really exciting because as we know, psychiatry is one of the most forward fields in medicine at this point in time. Advances in treatment modalities backed up by ever-expanding knowledge of in neuroscience have availed us to more pharmacotherapeutic options than ever. And this availability of wider options allows us a lot more berth to explore a personalized treatment for patients. And this means that, well, we can, explore and find out which medications are more effective for certain patients. Well, we can find out which dosages are optimized for them. And at the same time, we can also potentially avert, serious side effects from a medication. This evening, we are honored to have Dr. Daniel Dowd to share with us his insights into the use of psychiatry. Dr. Dowd is Vice President of Medical Affairs at Genomind. This is a unique personalized treatment platform that brings innovation to healthcare around the world. Currently, Dr. Dowd leads a team of medical affairs professionals to inform clinicians about genetic biomarkers that influence mental health outcomes. He's also responsible for the development, design, and testing of technological platforms to enhance the delivery of mental health. In addition, Dr. Dowd also initiates, develops and monitors the progress of pharmacogenetic trials and collaborates with key opinion leaders to enhance delivery of pharmacogenetic information as well as best practices. He has been a part of Genomind's expert team for more than 5 years, and he started off as a medical science liaison in 2015. This was quite some time ago. And before joining Genomind, he was working as a supervising pharmacist and pharmacy district manager for several companies. All right, I think we all of us can't wait to have Dr. Dowd start his presentation. So, okay, if you have any questions, we will have some time for Q&A. Please enter your questions into the chat box. Dr. Dowd, please. Thank you.
Okay, thank you, Dr. Tan. Appreciate the warm welcome. So here is today's agenda. We will talk largely about pharmacogenetic testing in the field of mental health and psychiatry. I will give a broad background of what pharmacogenetics is and also what it is not. I will talk about the Genomind Professional PGX test. There are, quite a few pharmacogenetic tests available. I'll highlight a couple of key points on our test. And then we'll look a little deeper into the science looking at pharmacokinetic genes or genes that affect blood levels of medications. And lastly, we'll look at a couple of pharmacodynamic genes or genes that affect sensitivity to medication independent of blood levels. Our test includes a total of 15 pharmacodynamic genes, but obviously we won't have time to go through all of them. So I've selected 3 that I think are very interesting. So what pharmacogenetics is and what it isn't, it is the marriage of pharmacology to genetics. So it is designed to help predict treatment outcomes, response, predict blood levels of certain medications. If you go back 5 or 6 years ago, one of the criticisms of pharmacogenetics was that it wasn't all-encompassing. It didn't provide all the information you would ever want about a patient's drug profile. And that's true. It doesn't provide all the information, but nothing provides all the information. No tool provides every piece of information. So you use this type of tool in conjunction with what you're already doing, getting a full patient history, looking for drug-drug interactions. This is just another tool to supplement what you're already doing. This should never be used alone. It should always be used in addition to standard practices. Pharmacogenetic testing currently is best at predicting risk. So we will talk about some genes later which predict risk of serious skin reactions with some mood stabilizers. We will talk about genes that predict risk of side effects because of how you metabolize medications. It's still a relatively young field, and it still does a better job at identifying risk medications as opposed to telling you which is the perfect medication. We're not at the point now where we can identify the perfect medication for a patient. What we can do is narrow the range and narrow your treatment options to a safer group of medications. So very frequently we get asked the question, what are your sources for identifying your genes and identifying your pairings of genes and drugs? Well, we look at three main sources when we build our product and when we update our test. The first is the FDA. The FDA, you may be surprised, but the FDA has about 270 medications where they have pharmacogenetic guidance right in the label. So if you were to, open up the insert for any one of these drugs, some very common medications have pharmacogenetic guidance. One common example would be citalopram. The FDA label says very clearly, if you are a poor metabolizer, do not use more than 20 milligrams of citalopram. The risk of QT prolongation is too high in those individuals. Aripiprazole would be another example. Tricyclic antidepressants, codeine, carbamazepine, there's dozens of them. In fact, there's hundreds of them, 270 medications to be specific. We also look at an agency called CPIC, CPIC. This is the Clinical Pharmacogenetic Implementations Consortium. This is an international group of researchers that standardize the field of pharmacogenetics. They create standardization for the terms. They create standardizations for defining a phenotype from a genotype, and they publish peer-reviewed guidelines. In fact, I think they have 25 guidelines currently, which includes hundreds of medications. In addition to CPIC, there is another international group, mostly European, that is called DPWG, and they do largely the same thing. They publish peer-reviewed pharmacogenetic guidelines, and we follow these guidelines. Lastly, we have done an extensive review of the literature. We have a database of about 13,000 articles. And most of the genes on our report are supported by either a meta-analysis, a systematic review, or what is known as a GWAS, a genome-wide association study. And these are generally the three highest tiers of evidence for drug-gene pairings. So let's switch gears now and let's talk a little bit about an actual test. What do these actual pharmacogenetic tests look like? Well, ours is called GenPro or Genomind Professional. And this test includes 24 genes in total. But these genes exist one of two subtypes. One of these subtypes is called Pharmacokinetic. And that's what you see on the left here. And on the right are your pharmacodynamic genes. Now, what we mean by pharmacokinetic is how does this gene impact blood levels or brain levels? You know, we're talking about psychiatry, so we're interested in brain levels also. So every gene on the left influences blood levels of certain psychiatric medications, and it influences them one of two ways. It affects how you absorb medications, or it affects how you metabolize medications. We'll talk more about that. Everything on the right is considered a pharmacodynamic gene. These are different receptors or transporters or ion channels that can affect your sensitivity to medications. Now, this sensitivity is largely independent of blood levels, but affects response to medications anyway. One example we'll talk about later is this MC4R gene, which actually increases your risk of weight gain with certain second-generation antipsychotics. So trying to look at this information in a different way, I've organized all of our genes by their therapeutic category. So again, we won't have time to go through every gene, but let's look at the different clusters of genes and how they can affect treatment outcomes. We have 4 genes related to depression and anxiety treatment, in particular SSRI and SNRI therapy. We have 4 genes related to medications for bipolar disorder or psychosis, schizophrenia. We have 2 genes related to weight gain with the 2nd generation antipsychotics. We have 2 genes related to ADHD treatment, 2 genes related to opioid sensitivity, 2 genes related to alcohol abuse treatments, and 2 genes related to skin reactions. Okay, and when I say that, I mean the severe life-threatening skin reactions like Stevens-Johnson syndrome. Now, this is particularly relevant for our audience today because these genes are predominantly found in East Asian populations. The HLA-B gene is found in about 10% of anyone of East Asian ancestry. So we'll talk a little bit about that, more about that. This is what our report would actually look like. It is an extremely detailed report. It's a total of 18 pages, and these pages are organized in different ways to make the information easy to understand. We provide the gene results in the first few pages. We examine how those results impact 130 different medications, and then we provide a plot or a graph of how these genes are how these drugs are impacted by these genes. And that's what you can see on page 1 here. So if you were to get an actual test, this is what the results would look like. The very first page is your actual gene results, what the lab has detected. The first column on the left there is your gene, followed by your actual gene results. And your genotype is always going to be a pair of letters. Those letters could be A, G, C, or T. In some cases, they will be S or L, depending on the gene. So in this top example here, we have a gene called SLC6A4. The genotype is SS, which stands for short. The phenotype is in parentheses, low activity. This is somebody who underproduces this gene. And then in the next column, we tell you what is the clinical significance of that. Why do we care about the results of this gene? And in this particular example, this gene is associated with poorer response to SSRIs. Probably not the best example for today's audience because this has mostly been studied in a Caucasian population. We will spend much of our time today talking about this BDNF gene because that has been extensively studied in East Asians. So the next component of the report, we take all of those genetic results and we apply them to different medications that you may be considering. So in this example, our report contains 130 psychiatric medications. And based on the gene results, the first thing we will do is make an assessment of drug exposure, okay? And drug exposure just means how much of this medication do we expect in the blood or in the brain? How exposed are we to this medication? Exposure is a measure of drug concentration over time. And the arrows predict drug exposure. So this is an example of a report where if I gave this person escitalopram, even at normal doses, we would expect a higher blood level of escitalopram. So the arrow represents the direction of drug exposure. So all of these medications in this example, we expect increased drug exposure. There's 2 things you can do about that. You can avoid those medications or you can dose reduce. And I think it's probably more common for clinicians to dose reduce. Some examples, if you happen to be a poor metabolizer of 2C19, the recommendation is to cut your escitalopram dose by 50% or your citalopram dose by 50%. If you're a poor metabolizer of a different enzyme, 2D6, for example, it's the same recommendation for paroxetine or fluvoxamine. So different genes affect different drugs, and we identify that on this section of the report. We will also identify any pharmacodynamic gene associations. So in this particular example, all 4 of these drugs are associated with higher odds of remission or response in Asians. So these might be reasonable drugs to select first because of the genetic profile, although we might want to dose adjust downward. The last part of the report here is what we call our summary pages. These summary pages will be specific based on the diagnosis. This happens to be a depression summary page, but this is just a quick visual interpretation of multiple different treatment options. In this case, here's several treatment options for depression. The drugs are shifted to the left or the right on different areas of this page. If a drug sits right in the middle of the page, that means none of the genes influence this drug. If it gets shifted to the left, there is a gene-drug interaction, a gene-drug risk. If a drug gets shifted to the right, there is some type of gene-drug benefit there. So if I was looking quickly at this page here, I would say to myself, well, fluoxetine and paroxetine seem like some of the best options here. They're shifted to the right. There's some type of gene profile predicts a better response to this drug, whereas there's a gene profile that predicts risk with citalopram and escitalopram. And the icons further define that risk. In this case, it would be a decrease in exposure. Okay, so that's the test. One of the frequent questions we get is, well, what evidence do you have to support this in the real world? What is the real world application of this? Well, a couple of years back, we worked with a large insurer in the United States known as Aetna. And we looked at Aetna's database, and we found that there were quite a few patients that used Genomind. So we decided to compare those people that used Genomind to those that did not. So we matched these individuals on multiple different criteria: age, disease state, severity of disease, income, location, medications used. We matched them on every parameter that we could, except that one group used the Genomind test, one group did not. And then they looked at expenditures. What were their healthcare expenditures in the first 6 months? And what they found was the group that got tested had about $2,000 lower healthcare costs in the first 6 months. That was quite a dramatic decrease in healthcare costs. So we said, well, what drove that? What was the cause of these lower costs? And found that there were decreased emergency room visits, 40% fewer emergency room visits, and 58% fewer inpatient hospitalizations. So these were the two main things driving these cost savings. About a year after that, we worked with an inpatient hospital called McLean, which is in Boston, Massachusetts. Now, these were severely ill inpatients, and we wanted to see if testing changed the outcomes for these patients. And we used one of the scales we used, one of the primary scales was this APA cross-cutting scale, which is a very broad spectrum scale. It looks at multiple different symptoms. And when you compared those that were tested to those that were not tested, there was a significant difference in outcomes, or there was a much greater improvement in symptoms in the tested group versus the untested group. And according to this APA cross-cutting scale, it was about a twofold difference between groups. So this is considered treatment as usual, and this is considered assay-guided treatment. And the bars represent the total improvement in symptoms. You can see there was a much greater improvement in the symptoms in the assay-guided treatment group. Though it's not shown here, we also saw improvements in substance abuse, a greater improvement in substance abuse in the tested group versus the untested group. We have about 4 or 5 other publications. We're happy to share them with anyone that's interested. So let's talk a little bit more about specific genes, starting with the pharmacokinetic genes. Okay, remember, pharmacokinetic genes predict drug exposure. There are 3 main families of pharmacokinetic genes that we look at. We look at the CYP450 family of genes, the UGT family of genes. These both are drug metabolism genes. And then we also look at something called PGP, or P-glycoprotein, which is a drug absorption gene. If you know anything about pharmacokinetics, you know that there are 4 parameters to pharmacokinetics. You know, four things that can happen to a drug once it enters the body. And those 4 things are absorption, distribution, metabolism, and excretion. Our genes focus on 2 of those aspects: drug absorption and drug metabolism. Okay. So this is the profile, or these are all the different possible phenotypes when it comes to drug metabolism. Okay. Let me introduce you to some of the terminology. Most people are considered extensive metabolizers, or EM. That is the same as a normal metabolizer. Those are people where if you give them a standard dose of a medication, they are very likely to be in the standard therapeutic range, which you can see represented in this chart. Now, most of us are normal, but some of us can be slow metabolizers, some of us can be fast metabolizers. The 2 types of slow metabolizer are IMs or PMs, intermediate or poor metabolizers. You can see poor metabolizers, or PMs, tend to have the highest increase in exposure. You know, even at standard doses, the PMs tend to be outside of the therapeutic window. Okay, to a lesser degree, the IMs. Poor metabolizers, or PMs, usually means there is a genetic variant that completely eliminates the protein. Okay, so if you're a poor metabolizer, that usually means you do not have a functional enzyme. And that's why blood levels or exposure can be quite dramatic in these individuals. Atomoxetine is a good example. If you are a poor metabolizer of 2D6, your atomoxetine blood levels can be 5-fold higher. It's quite a dramatic difference. Now, on the other side of the spectrum, you have the fast metabolizers, and they come one of 2 types: rapid metabolizer or ultra-rapid metabolizer. And the ultra-rapids tend to hyper-metabolize medications, and they are very often sub-therapeutic. These are the 3 different phenotypes that we can see with our genes. And based on these phenotypes, there are different treatment recommendations. Okay, most of your guidelines, most of your pharmacogenetic guidelines are for the 2 extremes here. They are for the poor metabolizers or the ultra-rapid metabolizers. Okay, here's a nice image to visualize the influence that these different phenotypes can have on blood levels. What we're looking at here is metoprolol, a very common beta blocker that's used for blood pressure. You would see the same profile for propranolol if you've ever used that for anxiety symptoms. But here is your normal metabolizer, and this is considered normal blood levels for metoprolol. In the ultra-rapid metabolizers, we see significantly decreased blood levels, about half. In the intermediates, we see significantly increased blood levels. And then for the poor metabolizers, it's quite a dramatic increase compared to the normal. So this is what you generally see with medications that are metabolized, that are sensitive substrates of certain enzymes, whether that be 2D6, 2C19, 3A4, 1A2. This is the general profile you see here. IMs, PMs have higher exposure. RMs, UMs have lower exposure. Again, if you have this information, you can dose reduce, or you can just avoid that medication and select an alternative that's not affected by that gene. This is how our report would identify the different genotypes and phenotypes. So here we have an example of CYP2B6 as well as CYP2D6. We have one on each side of the spectrum. An ultra-rapid metabolizer here, and then also a poor metabolizer. You can see these definitions, these genotypes right here, star 4, star 4. These are the actual alleles that were detected in the lab. Now, we take this information and we run it through an algorithm, and this is a standard algorithm that was developed by CPIC. Remember, CPIC, I mentioned earlier, has standardized the field of pharmacogenetics. Well, most labs use their algorithm. They will plug in these genotypes, and that will identify the appropriate phenotype. So in the ultra rapids, we may want to dose increase. For the poor metabolizers, we may want to dose decrease. Okay, again, we mentioned this earlier, but once we have the actual pharmacokinetic gene profile, we then want to apply that profile to the different medications. Here you have some SSRIs. Remember, the previous person was a poor metabolizer at 2D6. And so we expect elevated blood levels for any drugs that go through 2D6, 2D6, 2D6. So fluoxetine, fluvoxamine, paroxetine, we expect higher exposure. Also remember, this individual was an ultra-rapid metabolizer at 2B6. And in this case, sertraline is metabolized by 2B6, so we expect lower exposure here. So hopefully that's intuitive. The arrows are a prediction of exposure, or how much of this drug can we expect in the body. Increased, decreased, or just normal. Okay, so that wraps up pharmacokinetic genes. For the remainder of the presentation, we're going to talk about pharmacodynamic genes. And I've selected 3 pharmacodynamic genes, which I find interesting and relevant. The first one will be BDNF. This can influence SNRI response to medications, as well as SSRI. HLA-B, 1502. This is a gene that influences your risk of Stevens-Johnson's rash with carbamazepine, oxcarbazepine, phenytoin, and lamotrigine. And last, we have MC4R, which is a gene related to weight gain risk with some of the second-generation antipsychotics. Again, here are all of our different genes, all of our different pharmacodynamic genes. I just wanted you to see how comprehensive this gene panel is, but we will focus on BDNF, HLA-B, and also MC4R. Starting with BDNF. BDNF is brain-derived neurotropic factor. It is, you can think of it as a neuroplasticity-related gene. So normally the body releases BDNF, and that increases the connections between neurons. It literally increases the length of the dendrites so that they can make denser connections with one another. Following some type of neuronal damage or brain damage, BDNF can help reconnect different neurons and recreate pathways, neuronal pathways. This gene has been extensively studied. One of the things we know about this gene is that it comes 3 different genotypes, and you can see them listed at the bottom here. Most of us are considered VAL-VAL. Okay, that's the most common genotype. Anywhere from 70 to 90% of the world is a VAL-VAL. Then you can be a VAL-MET or a MET-MET. MET-MET is the rarest. It's usually about 4% to 15% of people are MET-MET. But what we tend to see is that those that carry this MET allele, either VAL-MET or MET-MET, there's a couple of things associated with that. Number one, it tends to be associated with more severe PTSD symptoms. Okay, so because there is reduced neuroplasticity, PTSD symptoms tend to be more pronounced. The interesting thing is that can be those symptoms can often be overcome with extensive exercise, and we'll talk about that in a minute. But first, I want to talk about the response to SSRIs based on this genotype. So let's focus on the chart on the left here, because this was primarily in an East Asian population. Okay, so almost 600 Asian patients, whereas the chart on the right was primarily a European sample, a French sample. So if we focus on the meta-analysis to the left right here, this looked at several studies and how this BDNF gene influenced antidepressant response. And they looked at SSRIs, SNRIs, some other antidepressants. And what they found is that carriers of the MET allele, either VAL-MET or MET-MET, had a better response to SSRIs. And when I say better response, I mean about a 74% greater likelihood of response. You can see the summary statistic right here, 1.74 in this forest plot. So most studies were positive and agreed with that outcome. So if you have this BDNF MET gene and you take SSRIs, you are more likely to respond to that particular SSRI. Okay. The reason I have this chart to the right here is because when they did this same type of study in a Caucasian population, a European population, they saw just the opposite. So Europeans tend to respond better to SNRIs if they have this VAL-MET genotype. So it's a very curious finding. It probably has to do with the frequency of these genes in the different populations. But nonetheless, we have this meta-analysis showing that in an Asian population, SSRIs have a higher likelihood of response with this MET gene. Now, I mentioned earlier about how exercise can impact this gene also, and that may sound kind of silly. It's well known that exercise improves depression symptoms, improves cognitive symptoms. It tends to benefit PTSD symptoms. But the reason it's interesting is because it has a more pronounced effect on people with this genotype. So let's start here on the chart on the left. This was a working memory study. The dotted line are those individuals who had the BDNF MET genotype. You can see there was a working memory deficit at baseline. Okay, so BDNF can worsen your working memory. There's a genetic deficit there. But with increasing amounts of exercise, that deficit was overcome, and then they actually exceeded the working memory of their VAL-VAL counterparts. So this is a perfect example of not a drug gene interaction, but a gene environment interaction. Some of us are naturally born with a working memory deficit based on this BDNF. but we can overcome that deficit by exercising. And the reason that happens is because exercise causes a surge of BDNF from all the skeletal muscles. Okay, so yes, exercise benefits everyone, but it has even a greater impact on these individuals. On the right, it's the same principle. This is how exercise influenced PTSD symptoms in those with the BDNF, with different BDNF genotypes. On the left are those who have the normal Val-Val genotype and the severity of their PTSD symptoms. So PTSD symptoms tended to be more severe in those who had the Val-Met genotype, but those who exercised had a significant reduction in their PTSD symptoms. Okay, so these genes are not only associated with drug gene interactions, but also drug environment interactions. Okay, next I'd like to talk about MC4R. This is the melanocortin 4 receptor. This is a gene related to satiety signaling. It helps tell us when we're full and when to stop eating. It regulates energy expenditure, again, eating habits. And the interesting thing with this gene is that it has been associated both with risk of weight gain, risk of diabetes, but also risk of weight gain secondary to a antipsychotic, mostly the second generation antipsychotics. It's well known that the second generation antipsychotics cause weight gain, but in some individuals, it causes about twofold greater weight gain. So your possible genotypes are CC, CA, and AA. About 10% of us have the AA genotype, and this is considered the risk variant. So if you look at this study that was done a few years back, this is a study of total amount of weight gain following treatments with olanzapine, quetiapine, aripiprazole, clozapine, risperidone, the standard second generation antipsychotics. And the first was the discovery cohort. So they had a group of patients who were all on second generation antipsychotics. They all gained a little bit of weight. And then they looked at the entire genomes of every individual to see if any gene was more common in the high weight gain individuals. And what they found was that the MC4R AA genotype, the green bar here, was associated with about a twofold greater weight gain. Okay, so here's your CC genotype, here's your AC genotype, here's your AA genotype. So this was the discovery cohort, and they said, well, let's test this in different cohorts to see if this trend holds up across different cohorts. So they did a replication cohort, they did a second replication and a third replication, and every cohort had the same results. The AA genotype was associated with almost twofold weight gain in almost every cohort. This study was done about 5 years ago. Since then, there's been a much larger study done, and I think it was about 1,200 Chinese individuals, and it largely replicated this. The AA genotype individuals had the greatest weight gain. So you can imagine if you knew this information ahead of time, you might consider a lower weight gain option. You might consider starting metformin. When you start an antipsychotic, metformin has been known to offset antipsychotic-induced weight gain. So it's important information to have before you initiate these therapies. Now, the last gene we'll talk about here is HLA. There are two types of HLA that are on our report. One is HLA-A, one is HLA-B. We will focus on HLA-B for now, okay? HLA-A can be found across all populations across the world. but HLA-B is almost exclusive to the Asian population, primarily East Asian. About 10% found in those of East Asian ancestry. If you are positive for this genotype, it increases your risk of Stevens-Johnson syndrome or toxic epidermal necrolysis anywhere from 10-fold to 100-fold. So, carbamazepine risk, oxcarbazepine risk, and phenytoin risk, it's fairly rare to see Stevens-Johnson syndrome with these medications. But when it does happen, it's life-threatening. In most individuals, it's very rare, but if you're positive for this genotype, it can be anywhere from a 10 to 100-fold increase in risk. So if we look at this chart right here, let's look at carbamazepine. This normally occurs in 0.06% of the population, so that's rare. But we're concerned about it because it's so severe. Now, those that have this HLA-B genetic variant have a 113-fold increased risk. So it bumps us from a 0.06% to a 6% risk of Stevens-Johnson. This increase in risk is so dramatic that this is considered a contraindication. If you are positive for this genotype, you should not use carbamazepine, oxcarbazepine, or phenytoin. With lamotrigine, it's an increase in risk as well, but it's not quite as dramatic. It's only about a 2.5-fold increased risk with lamotrigine. I still wouldn't want to take the chance of using this medication if I have an increased risk of a life-threatening rash. Okay, so a little bit about the process itself. How are these tests conducted? One of the questions we get is, well, how much blood do you need for this type of testing? And we don't require any blood. This is all done with a cheek swab. It is a buccal swab. We use 2 samples. There are two swabs. Rub them on the inside of the mouth for 30 seconds, and that's enough to generate a sample. Those samples get sent to our lab, which is in Philadelphia. We can usually get the results generated in about 3 to 5 days, and then the report is sent to our international partner labs. ScienceWork would get those results relatively quickly. One of the other things is that any provider that orders this type of testing has the availability of a pharmacy consultant. And so that will either be me or members of my team. We will go over the report. We will look at any significant drug-gene interactions. We will talk about different treatment options. We can use some of our software that we built in the background to look at drug-drug and drug-gene interactions. So these are the 5 steps of obtaining a sample from your patient and then getting the results and then reviewing the results with some experts. So that wraps up my presentation. I'll be available here for a few minutes for questions and answers. And here you see the contact information for ScienceWork. So with all that being said, please review this final slide here, and I am open for questions. Now, Dana, as long as I'm sharing, or Dana and Dr. Tan, as long as I'm sharing my screen, I don't have access to the questions. So if you have any in the chat box, please relay them to me.
Okay. Thank you, Dr. Dowd. I think that presentation was really engaging and well, clarifying in more ways than one. I think, well, first of all, as a frontline clinician, I'm quite sure, well, many in the audience will agree with me that, well, the problem with psychiatric treatments is that usually it takes a bit of time before we can see any effect. And increasingly these days, we are realizing that patients really cannot wait. And sometimes when they experience side effects to the medications, they have to endure several medication changes. I think that actually further demoralizes them. And the thing is that I find that well, personally, when I use pharmacogenetic testing, what I've realized is that it actually does help guide to some extent, well, what are the appropriate treatments? Okay, but one question that sometimes I encounter with some of my patients is that, okay, so we try a medication that is recommended, but what happens when it doesn't work? It is a not an uncommon question. I've done pharmacogenetic testing for a few of my patients, and well, some take to it. Some use that information, and or rather, I use that information, and I've had pretty good results for a couple who we previously thought were treatment resistant. But then again, there were also others whereby we tried a couple of the treatments, and those didn't really work. So what is the next step for patients who have actually gone through some of the recommended treatments, but they still didn't work? And assuming that we've already excluded other psychological as well as social triggers or factors.
Yeah. Well, remember, one of the first things we talked about is that this is one part of the treatment puzzle. So, you know, we know that using pharmacogenetic testing helps narrow your range of medications. Okay, but there are many things that influence an outcome to a drug.
Yes.
And so while we can narrow the range, we still don't have the ability to pick that one single perfect drug. And you know, we can minimize side effects, but you know, there still is no guarantee of outcomes. The outcomes are better, but unfortunately they're not perfect. One of the things me and my team has done is we've created an extensive database of treatment-resistant options, both for depression, for anxiety, for bipolar, for schizophrenia, for substance abuse treatments. We've combed through the literature and looked at the evidence to support some of these third tier or fourth tier options. So in doing these consults with us, you would have access to that database. We can go through and say, well, your patient has failed 5 different medications. Let's look at some of these third tier options and the evidence to support these third tier options. One of the things I didn't mention on the test, we have a couple of genes that predict response to some augmentation strategies. For example, we have a gene related to folic acid and how well your body uses folic acid. And based on that gene, we may recommend folic acid supplementation, because we know that that is an underutilized treatment that helps increase antidepressant response and possibly antipsychotic response.
Okay. And another question that I have, when you take them, when we send a sample over, what relevant information, patient information should we be sending over? Things like past treatment records, dosages used, measurements, blood tests, concerning serum levels. What do we send over?
Yeah, so we have a standardized requisition form, and what we usually ask for is all the standard demographics, you know, age, diagnosis. We always like to know previous treatment failures and current medications, so that if we do a consult, we can review the prior treatment failures ahead of time, and then it helps us develop a treatment plan. The last thing we want to do is say, you know, have you tried sertraline? You know, let's try sertraline in this patient if they failed sertraline 6 months ago. So it's all the standard information. Diagnosis, age, previous treatment failures, current medications.
Okay, and sometimes for some of my patients, right? You know, patients tend to self-treat, and we do have, well, I would say a fairly substantial number of patients with psychiatric illnesses who, for example, use nicotine. They are on vapes, or sometimes they might also be on certain fat burners. How does that affect your reading of the results and your recommendations?
Good question. We've incorporated several non-prescription medications into our software.
Yes.
And so it will assess things like marijuana, both cannabidiol and THC. It will assess how smoking influences the metabolism of certain medications. So, for example, let's take olanzapine as an example. It's well known that smoking can reduce the exposure to olanzapine, but some people have a genetic variant where that's even more dramatic, and the change in exposure is even more dramatic. So it's also important to, when you're filling out this requisition form, to include any non-prescription options. So we include a checkbox for smoking. We also include a checkbox for coffee consumption. Believe it or not, if you drink more than 3 cups of coffee per day, that can influence your metabolism of certain drugs. So we try to be as comprehensive as possible and account for drugs, environment, and diagnosis.
Okay, thank you, Dr. Dowd. I think this has been really helpful. And before we close, I would like to ask the audience if you have any further questions here. Okay, we have a question here. All right. Okay, I have a question from Dr. Chua. Her question is the evidence for pharmacokinetics equally strong as for the pharmacodynamics aspect of the report? Yeah.
Excellent question. So the pharmacokinetic genes, that's literature that's 30 or 40 years old. So when we first started looking at pharmacogenetics, it was with CYP2D6 and CYP2C19 and all the pharmacokinetic related genes. So that is a much richer literature base. Pharmacodynamic genes are more recent, maybe 10 to 15 years. So there is a larger literature base for pharmacokinetics. If you look at the CPIC guidelines, and if you look in the FDA labels, what you'll find is that most of the guidelines are around the pharmacokinetic genes, okay? Just because there's much more literature to support them. Most of the PK-related guidelines are considered level 1, whereas many of the pharmacodynamic guidelines are considered level 2 or 3. So yes, the evidence base is bigger for pharmacokinetics. All the authorities would consider it stronger for pharmacokinetics, but that largely has to do with the amount of literature that's out there. I expect over time that these pharmacodynamic genes will get higher and higher scores. The MC4R gene is a perfect example. That started off with a score of 4, I think. It then got bumped up to a score of 3. It now is a score of 2. So, as more evidence is developed, these gene drug pairs get better and better scoring.
Okay. And is there an option for us to request for additional tests? Because as we know, well, psychiatry is into rather exciting times. Last year in Singapore, we had brexpiprazole, we had and earlier this year, late last year, we had cariprazine, becoming one of our options for treatment. So well, for example, if I receive a report and I find that one of my candidate or potential medications or treatments is not on that list, is there the possibility of us calling the lab and requesting for an accessory or an adjunct report for this particular new medication that we're thinking of trying? And also, how long are the samples kept for?
So we try to be as current as possible with the report. So when cariprazine made it to the market, we put it on our report within a couple of months.
Yes.
The newest medication would be lumateperone, which we still haven't added to our report yet, but we plan to. If there is a drug that is not on the report, what I would recommend is that you schedule a consult with the clinical team, with the medical affairs team, and we will walk you through all of the genes that are relevant for that drug. So it's very difficult to make a report retroactively because the way our software is set up, but we're happy to talk to you and walk through that drug. For example, we have we do international business in Great Britain. And many of the international medications that they use, like amisulpride or sulpiride, are not on our report. But we do consults daily with our English partners to go over these medications. So yes, we're happy to do that.
All right. Thank you very much. Yep. Okay. All right. Thank you, everybody. I think this has been a wonderful session, and what we will do is that if there are any further questions, please feel free to email Mr. Sabah, and I would like to take this opportunity to thank Dr. Dowd as well as the organizer, and I wish all of you a very good evening. Thank you.